Good morning. Several diseases of skin can also present with oral manifestations. One such condition is lichen planus. Lichen planus is a common, chronic, immunologically mediated disease of skin and mucosa. The term lichen planus is derived from the Greek word lichen, which means tree moss, and the Latin word planus, which means flat. This term was coined by the English physician Erasmus Wilson in the year 1866. The etiology of lichen planus is unknown. The exact triggers which cause this immune-mediated disease is not clear. But several factors have been implicated in the etiology, and these include stress, food allergens, environmental allergens, a genetic tendency, certain drugs, systemic illnesses. All of these, or any one of these, can result in a state of altered immunity, which results in lichen planus. So, to sum up, lichen planus is a multifactorial etiology. Continuing with the pathogenesis, oral lichen planus is a T-cell mediated immunological disease where the cytotoxic CD8 plus T cells trigger apoptosis of the basal cells of the oral epithelium. Antigenic stimulation is the initiating factor or event. This results in a focal release of regulatory cytokines by the macrophages and the Langerhans cells, which are resident within the epithelium. Further, the endothelium in the connective tissue upregulates adhesion molecules like ICAM and ELAM. This results in recruitment and retention of T cells at the subepithelial connective tissue area. Cytotoxicity of basal keratinocytes is mediated by T cells, and this results in apoptosis of the basal keratinocytes. Coming to the clinical features, the skin lesions or the cutaneous lesions of lichen planus are characterized by 5 Ps. They are pruritic, purple, polygonal, planar papules and plaques, and they appear rather as seen in the picture here. Furthermore, they usually have thin, fine, lace-like striae over the lesion, and these are termed as Wickham's striae. The age of predilection is usually middle-aged, and women are seen to predominate with at a ratio of 3:2. The course of disease can be protracted. There will be periods of remission as well as exacerbation. This is the lesions are seen to wax and wane over time. These are some examples of the skin lesions of lichen planus: purple pruritic plaque-like lesions and covered by thin white striae, lace-like striae, which is called as Wickham striae. These classical flat-topped violaceous papules and plaques of lichen, over time they become thick and keratotic as seen in the last picture. The cutaneous lesions consist of pruritic, violaceous, flat-topped papules, which may coalesce focally to form plaques with a very fine grayish-white line called as Wickham's striae. Multiple lesions are seen, and they are usually characterized by their symmetrical distribution, especially along the extremities, often on the wrist, elbows, or the flexor surfaces of limbs. Hyperpigmentation may result from melanin loss into the dermis from the damaged basal cell layer. This is because apoptosis of the basal keratinocyte results in loss of melanin into the underlying connective tissue, where they are phagocytosed by melanophages. There are some characteristic features that we can see along with lichen planus skin lesions. One of them is the Cobner's phenomenon. This is seen as development of new skin lesions which extend along areas of injury or irritation. So in the pictures here, we can see new lichen planus lesions developing along the scratch marks and along areas which are constantly involved in friction. There are some diseases or conditions which are associated with lichen planus. The first is Greenspan syndrome. This is an old association, probably related to a lichenoid reaction, which associates lichen planus with diabetes mellitus and vascular hypertension. Now, these are possibly examples of oral lichenoid reactions, what we now know them as lichenoid reactions, and these show an association between these three entities. Usually, patients with Greenspan syndrome have medications for vascular hypertension and diabetes, which could probably exacerbate the lichen planus skin lesions. Additionally, there has also been an association between lichen planus and hepatitis C infections. Coming to the oral manifestations of oral lichen planus, these are characterized by the striae of Wickham. That is, they are characterized by radiating white, gray, velvety, thread-like papules in a linear, annular, lacy, or retiform appearance. Now, the arrangement is usually the most common arrangement is in a reticular pattern, which is seen against a reddish or slightly erythematous mucosal background. Most of the skin lesions will show the characteristic 5Ps, but when we come to oral manifestations, the only indication will be the striae of Wickham. The Wickham striae, they are seen as asymptomatic, usually bilateral and symmetrical. That is a characteristic feature that we tend to see in classic oral lichen planus. These are seen over the buccal mucosa and to a lesser extent on the lips, sometimes on the tongue as thick plaques, or on the palate. Gingival presentation may also occur. The oral lichen planus has 6 classic clinical presentations. They are reticular, which is seen as thin striae, erosive and atrophic, which have areas of redness or erythema, plaque-like, characterized by thick lesions, papular, containing fluid-like blisters, and rather bullous forms, which is very rare. A little more detail on the clinical types of lichen planus. Reticular lichen planus is seen as interlacing white keratotic lines or Wickham striae, which are seen to produce an annular or a lace-like pattern. The most common sites are buccal mucosa and the buccal vestibule, followed by tongue and later the gingiva. On the gingiva, these lesions tend to be termed as desquamative gingivitis because the mucosa tends to be easily removable. The lesions are seen bilateral and symmetrical, and they produce minimum clinical symptoms. Erosive lichen planus is the next most common variant, and here we can see a central area of ulceration, which is covered by a fibrinous plaque or pseudomembrane, and peripheral to that, keratotic striae may be seen periphery to the site of erosion and erythema. Erythematous or atrophic lichen planus appears as smooth, red, poorly defined areas, and they can be seen in conjunction with reticular or erosive variants. Now, if you don't see the striae of Wickham, it is often a little difficult to identify these as lichen planus, and they can be misdiagnosed as erythroplakia. The attached gingiva is the most commonly involved form in this type of lichen planus. It presents on the gingiva as chronic desquamative gingivitis, which is red, diffuse, painful condition of the gingiva, and is also a common manifestation for several dermatological diseases. These images show the dorsal tongue showing extensive ulceration caused by erosive LP. The next image is of atrophic lichen planus appearing as desquamative gingivitis. Another less common variant of lichen planus is the plaque type of lichen planus or hypertrophic form, which tends to resemble leukoplakia clinically. The plaques range from slightly elevated to smooth and flat. They are multifocal in distribution, and the most common site of occurrence is the dorsum of tongue and uncommonly buccal mucosa. Bullous lichen planus is a rare variant which is seen presenting as bullae, that is large fluid-filled blisters, which range from a few millimeters to centimeters in diameter. Vesicle and bulla formation, these tend to rupture and leave a painful ulceration. Some uncommon variants are also seen. These include the hypertrophic, atrophic, bullous, follicular, and linear forms of lichen planus. Lichenoid reactions represent a group of lesions which are similar to lichen planus clinically and histologically, and the etiological or triggering factors include dental restorative materials, graft versus host disease, drugs, flavoring agents in food, and tobacco chewing. Several drugs are also associated commonly with lichenoid reactions. These include antibiotics, antihypertensives, antimalarials, diuretics, cold compounds, and non-steroidal anti-inflammatory drugs. Looking at the histopathology of lichen planus, this is characterized by hyperparakeratosis or hyperorthokeratosis. Along with this, there will be increased thickness of the spinous layer, which is termed as acanthosis, along with intracellular edema of the spinous cells. There is a characteristic appearance of the retiridges and the retipegs. This is termed as a sawtooth appearance of retipegs. Adjacent to the epithelium in the connective tissue, there is a band-like subepithelial infiltrate of T cells and histiocytes, which are classic features seen in lichen planus. Additionally, liquefaction, basal cell liquefaction degeneration may be seen. Degenerating basal keratinocytes can form civet bodies or colloid bodies, and the decreased strength of the epithelium may cause cleft formation, which are described histologically as Max-Joseph spaces. Of all these features, the most classic features that we can see are the sawtooth appearance of the retiridges and the subepithelial band-like lymphocytic infiltrate. For further confirmation of lichen planus, it is important to do a indirect or a direct immunofluorescence. Direct immunofluorescence requires that a biopsy be taken, fixed in Michel solution, and stained with immunofluorescent dye. The characteristic pattern that is seen is that fibrinogen is deposited in a linear or shaggy pattern at the basement membrane zone. This is characteristic for lichen planus. Now, lichen planus is important because it has a potential for malignant transformation, be it ever so slight. It ranges from 0.3 to 3%, and the highest risk is seen for erosive and atrophic forms of lichen planus. Coming to the differential diagnosis, oral lesions which appear superficially similar to lichen planus include lichenoid reactions, leukoplakia, candidiasis, other dermatological conditions like pemphigus and recurrent aphthous ulcers and lupus erythematosus. Treatment of lichen planus includes corticosteroids as a first line for erosive lesions and topical vitamin A. Further management may require systemic application of corticosteroids. With that, we end this brief session of lichen planus.